Why medical coding globally is such a difficult paradigm, even without AI, a constantly moving target. This is a question that has plagued the medical coding industry since the introduction of the International Classification of Diseases, or ICD coding system. Originally used to classify disease and illness, and then becoming an essential business financial component in 1977 for the ICD system and current procedural terminology, or CPT, mandated by CMS and Medicaid in 1983 for healthcare providers in order to get paid by the government and insurance providers. Since that time, there's been an ongoing struggle as to how any coding system utilizing an alphanumeric structure attached to or paired with specific medical terminology can be used to accurately report medical care. Now, two purposes. One, the reporting of disease, and two, requirement for payer reimbursement to healthcare facilities. Does any coding system effectively match the way medicine is practiced globally by medical providers? Can the complex paradigm of time and healthcare practice fit into any coding or reporting system? The answer historically and presently is a resounding no. Besides the basis of practicing healthcare, the reporting system can't abstract the medical care with 100% operational transmissibility. Meaning, a coding system just doesn't completely and comprehensively describe diseases, and there are numerous papers in the nomenclature to support this. But just from a pragmatic standpoint, how can a fixed, static system of words and phrases fully describe patient care? The system can't lead or imply what a provider meant, and with that small example, there are so many communication obstacles in the way from a coding perspective. If we strictly focus on the mechanics of any coding system, whether ICD-10, CPT, SNOMED, or any other system in place now or contemplated in the future, they simply don't match up very well with real-world coding of a medical record or encounter. Even EMRs providing a templated paradigm reduces accurate reporting potential of any given case, as the provider tries hard to fit descriptions into the narrow corridor of choice selection from an EMR, and time toward what may or may not fit real-world events. And then that may get scrutinized by payers based on continuous changes to thresholds for any given diagnosis. One example scenario that continuously comes up is that work and processes were provided to rule out certain diagnoses, critical both in the provider training toward a diagnosis and to establish the reason for illness. So therefore, was a rule-out diagnosis and the work involved somehow lessened from an administrative reimbursable perspective, even though the effort of time and expense was performed to rule out the diagnosis? The answer is quite often yes. While there are rules that render judgments to these particular paradigms, the goalposts are continuously moving based on a whole slew of factors, but mostly from a financial perspective, payer versus provider and the tug of war. And with that, we can make the statement that any coding system originally designed to report diseases becomes flawed. No coding system should ever govern healthcare unless we want to dilute the quality of healthcare and perhaps the most important attribute, the human condition. Now back to the raw coding mechanics. Without an answer key for right answers, coding becomes a moving target of interpretation. This statement reaches into the clinical determinations also. Medical board tests have an answer key. Why can't coding? We'll leave this for our viewers to contemplate. All that said, this is the system utilized globally, and while we have concepts and ideas to make the system better, this is what healthcare globally has to work with. One of the concepts mentioned before is to create templated medical records with pull-down menus providing either clinicians or coders access to the ICD-10 corpus as an example. While this sounds like a method that could work, essentially providing a structure to a system by limiting choice, what happens when diagnoses are miscategorized due to the limits of the choices provided, or how they're presented? At this point, let's now bring in generative AI technology such as ChatGPT as an example. This example shown represents how AI perceives the ICD-10 corpus, specifically ChatGPT, yet it is far from the real world as we are demonstrating in the example on the screen. The question presented to ChatGPT is giving us all the examples of terminology that represents M95.9. ChatGPT lists the following terms: acquired skeletal deformities unspecified, musculoskeletal system anomalies not elsewhere classified, connective tissue deformities of unknown origin, unspecified acquired musculoskeletal abnormalities, non-specified acquired skeletal malformations, deformities of the musculoskeletal system etiology unknown, acquired connective tissue anomalies unspecified, unspecified acquired skeletal anomalies, unknown origin musculoskeletal system deformities, and unspecified acquired deformities of bones and joints. The phrase old fracture deformity left inferior pubic ramus was not offered by ChatGPT, and frankly it's not surprising as this is a rare description of M95.9. In the case of AMI, we would apply this old fracture deformity left inferior pubic ramus only after, and I repeat only after, we have subject matter experts review the medical record in its entirety for things such as subtle context and other IP clues which would never be picked up by machine learning applications. True, if someone physically corrected the medical record or provided human input and applied M95.9 to the phrase old fracture deformity left inferior pubic ramus, ChatGPT would learn, which is another way of saying assimilate for any Star Trek fans, that terms that it would be picked up if it ever came up again. But what are the user skill sets, and would you want to apply this mapping without looking at any subtle context? Machine learning in the coding model assumes all input changes are correct. It's a flawed model subject to garbage in, garbage out, and we can't emphasize the importance of this more than in this paradigm. So with that, let's take a deeper dive into a good standard for accuracy. Who becomes the gold standard? When we talk about the gold standard, we're referring to a congruence of agreement on what is correct. Yes, a consensus or Delphi method would work, but that is very hopeful and time-consuming to get agreement. Imagine 4 potential correct options and trying to get a consensus on one. Now let's broadly identify who would be considered a gold standard. Let's start from the most broad and then get more specific. Is Medicare or Medicaid a gold standard? Yes and no. Yes, if it is specifically for Medicare reimbursement and nothing else, but the problem is there could be a lack of agreement on the interpretation of the rules. Every human auditor is open to interpretation regarding the rules laid out by the government. And in this example and all payer side examples, the system is designed to minimize specificity from the coding corpus. Are the insurance companies or payers like United Healthcare, Blue Cross Blue Shield, Aetna, or Humana gold standards? Well, each one individually, yes, could be a gold standard, but each one has specific rules that guide reimbursement, and again, subject to the human component, which can govern acceptance or denials. Denials cost time and money, mostly to overturn a denial. And just like the government, the system is designed to minimize the value of specificity from the coding corpus. In the provider-payer paradigm, we look at payers that pull from the providers to reduce the reimbursement. Are healthcare providers like hospitals, clinics, physician practices gold standards? Well, unfortunately, coding departments believe they are, and this too is subject to the human component. Are organizations like AHIMA, AAPC, AHA, or AMA gold standards? Only broadly, yes, but not as adjudicators of the results in the real world. Are practitioners like physicians and nurses as experts a gold standard? Are certified subject matter experts such as nurse coders and medical coders? In the provider-payer paradigm, providers are looking to disseminate as much specificity in the coding of a medical record and inclusion of as much documentation to exact a higher level of reimbursement. We can all draw the conclusion of how the system operates as a push-pull system and the flaws that it generates. Is the EMR a gold standard? Well, yes, but only in the context of satisfying and applying the non-complete end result. While conforming with an EMR, does the care match up with the templated pull-down menus? No. Plus, templated choices as identified in the ChatGPT reference is not the type of language or terminology used by clinicians. They don't speak like that. Practicing medicine is not black and white, so the answer to this would be no. However, EMRs would love nothing better than to template coding results and get the government and payer buy-in and call it a day. It seems like things may be turning this way, and introducing constrained processes degrade providers to mechanics and administrators. One of the most important diagnostic tools that gets lost in this system is in the ability of a provider to listen to patients, an art omitted due to the demand of time and money on the encounter. All the emotional nuances that good providers continually evaluate as part of the process and work into any patient encounter get lost. Providers are forced into the EMR and payer paradigm to see as many patients in limited time. Is that good healthcare? Anyway, back to the subject. Can AI solve the coding dilemma? or is some other outside intervention needed to tighten up the variability? The answer might surprise our viewers, but no, not by itself. So what are the remedies? Tuning or training are terms in use today by AI. Teaching? We'll leave that open because you can't fully teach when you have moving goalposts. Document consistency? Essentially templates for all medical records. Gold standard creation? Is this even possible? Yes, but specifically focused and not broadly generalizable. Are there others? Maybe. From our expertise in the identification of terminology from unstructured text, it is true we do apply a much more significant amount of automation to various record types without training to the processing of medical records at the highest degree of accuracy. Why? Experience is a big factor that can't be discounted, and not just the exposure of medical data. Exposure to medical data doesn't cut it, but others continue to pursue this paradigm, hoping that processing power will absorb everything. Keep in mind the term accuracy being a subject for future videos. In addition to the time, we bring to bear the raw accumulation of unique terms not documented in the typical nomenclature into our ontology dictionaries, and the coding rules and guidelines outlined in previous videos. This is a big deal. But to ensure and guarantee our ability to work a gold standard on demand, with narrow focusing from payers, providers, subject matter experts, or anything else, who by the way exclaim themselves as experts with their gold standard, we are able to apply human subject matter expertise where needed to apply expectations and interpretations and the subtleties paralleling what a site wishes to apply to medical records. This concept is not scientific, but one of human relations. To go a step further, records that demand special attention are reviewed by AMI subject matter expertise within our operational interface. Why? Because it gives a layer of human relations needed for this paradigm to be accepted. Since our AI tools do the majority of the heavy lifting, and in quite a few examples all the heavy lifting, it becomes easy and natural for the AMI team of highly skilled subject matter experts, along with our tools, to timely QA results from the AMI platform where needed, before depositing the results downstream. This provides surety, a second eyeball to the output created, ensuring clinical and coding customer satisfaction at the highest and most premier level. Not only are AMI's team subject matter experts for AMI's output, but they also become human interfacing project managers working directly with stakeholders assigned to the coding results on the customer side. They assimilate and interpret the analog patterns into our digital output. More importantly, their role is to interpret any customer gold standard and assimilate those results just as a new human coder hire would, to learn the gold standard rules from their employer. Thank you for watching this video. Be sure to like and subscribe.